onchocerciasis. So, by introduction, onchocerciasis, also known as river blindness, is a parasitic disease that is caused by the filarial worm Onchocerca volvulus, and is said that it's the second leading infectious cause of blindness. So this parasitic disease is transmitted by repeated bites. So not just a single bite, repeated bites of the infected black flies of the Simulium species, that's the Simulium damnosum, which acts as a vector. And the vector breeds in fast-flowing and oxygen-rich rivers in affected areas. Onchocerciasis occurs mainly in tropical areas. More than 99% of infected people live in 31 countries in sub-Saharan Africa, in which Nigeria is one of them. And onchocerciasis is also transmitted in areas in Brazil and Venezuela, as well as in Yemen. So regarding the pathophysiology, I'll start talking about the life cycle first. So it starts with the black fly when it takes blood meal. Okay, and then the larva that is infected into the human body is in the L3 stage. So this L3 larva enters the bite wound, and then in the human stage, it goes into the subcutaneous tissue. So for this takes about 6 to 12 months for this L3 larva to develop into adult worms that will reside in the fibrous subcutaneous nodules. And this adult worm consists of one male adult worm and about one or two female worms. So these worms, they have a lifespan of about 10 to 15 years. So when these adult worms become fertilized, they produce about 100 to 1,000 microfilaria. So these microfilaria, they are unsheathed and are found in the skin and in the lymphatics of the subcutaneous tissue, but also in the peripheral blood, urine, and sputum. So as you can see there, where the microfilaria is, there's a sign showing D. So it signifies that is the diagnostic stage. And this depends on their association with the Wilbechia endosymbiont, just like the filaria. So the microfilaria, their lifespan is not as long as that of the adult worm. They have a lifespan of about 12 to 15 months. So during this stage, another black fly now takes a blood meal from the human and ingests the microfilaria. Then the microfilaria would penetrate the midgut of the black fly and migrate to the thoracic muscles of the black fly, where they become the L1 larva, and then the L2 larva, and then they migrate to the head of the black fly proboscis, and then ready for another human meal. So the actual route of entry into the host eye is not clearly understood, but proposed routes include the bloodstream, the sheath of the posterior ciliary muscle and the nerves, the cerebrospinal fluid, and sheath of the optic nerve. So the presence of microfilaria in the eye and in the skin usually does not cause the disease. On the other hand, it's the death or the dying microfilaria that trigger an inflammatory cascade that now leads to the tissue damage associated with this disease. So the signs and symptoms of onchocerciasis, they do not appear until after the L3 larva mature into the adult worm. That is between 6 months to 2 years after the initial infecting bite. And the onchocerciasis can cause pruritus, dermatitis, onchocercomata, that's the subcutaneous nodules, and the lymphadenopathy. The most serious manifestation consists of ocular lesions that can progress to blindness, but constitutional symptoms like weight loss and generalized myalgia can occur. So in the skin, they can have intense itching, swelling, inflammation, depigmentation, hyperpigmentation, rash, nodules, skin atrophy, hanging groin. And then in the eyes, they can have they can have findings from visual impairment to even permanent blindness, clouding of the cornea, light sensitivity, glaucoma, eye pain, redness. So we have some terms that are used to describe these skin lesions based on their type. So we have the acute papular oncodermatitis, and then the chronic papular oncodermatitis as the CPOD, which is the most common. Then lichenified oncodermatitis, onchosarcoma, which is the subcutaneous nodules. Then onchocercal atrophy, then SORDA, which is a severe pruritus and darkened skin, usually confined to one limb. Then we have the leopard skin, which are patchy depigmentation, and the elephant skin. There's also hardening of the skin there. And then the lizard skin, there's hardening with associated scaling of the skin. So the first image is showing the subcutaneous nodule, that's the onchosarcoma, while the other image is showing the keratitis. And then this one with the hypopigmented lesions, that's the leopard skin. So we're seeing this patchy depigmentation in both of the lower limbs and even on the hand. Then the image next to it is the SORDA with a differential darkening and pruritus of one upper limb. So diagnosis is based on a skin snip for assay. So you either assay for the microscopy, where you can visualize this microfilaria, or even now that PCR DNA amplification is done. Then there's this traditionally there was this skin patch test that was done, and this was based on the Mazotti reaction, which is a complex seen in patients after they start undergoing treatment with onchocerciasis with diethyl carbamazine. And it can be life-threatening, and it's characterized by fever, urticaria, swollen and tender lymph nodes, tachycardia, hypotension, arthralgias, edema, and abdominal pain that occur within 7 days of treatment with this drug. Then we can also do a slit lamp examination of the anterior chamber, ELISA to detect antibodies, and ultrasonography of the nodule to detect the worms or the changes caused by this parasite. So the treatment for onchocerciasis is ivermectin, 150 micrograms per kg 6 monthly or yearly for at least 10 to 12 years. Another drug that can be given just like in the lymphatic filariasis is the doxycycline to deplete the Wilbachia. So this is given at a dose of 100 milligrams per day for 6 weeks. And then there are newer drugs now like the moxidectin and the suramine that may be used. It is controversial regarding the use of prednisolone to minimize Mazotti, and also surgical strategies like the nodulectomy may not be feasible, as patients may have multiple nodules. So the differential diagnosis for this disease, we have lymphatic filariasis, atopic dermatitis, leprosy, autoexcitemization, insect bite, lichen planus, scabies, stasis, dermatitis, lower. So the complications, we have the noduling disease, which is an unusual form of epilepsy that is associated with onchocerciasis, and it can present with atonic neck noduling, absence seizures, myoclonic neck seizures, or even generalized tonic-clonic seizure. And there's the Neckalanga syndrome, that is the above that is associated with stunted growth. Then this can also result to permanent blindness, and this blindness is as a result of keratitis, formation of panels, corneal scarring, optic atrophy, open angle glaucoma, and chorioretinitis. So for the prevention, there have been several prevention strategies for this disease. The first being in 1974 to 2000 and was carried out in West Africa. That's the ONCHOCERCIASIS Control Program. And this mainly used insecticide sprays against the black larva. This was later supplemented by large-scale distribution of ivermectin in 1989. And then another program, that's the African Program of Onchocerciasis Control. This was launched in 1995, and the main strategy was sustainable community-directed treatment with ivermectin and vector control with environmentally safe methods. Then another strategy in 2016 was the expanded special project for the elimination of neglected tropical diseases. So this also use ivermectin. And then in the Americas, they have a program, Onchocerciasis Elimination Program of the Americas, which began in 1992 with the objective of eliminating ocular morbidity and interruption of transmission throughout the Americas by 2015 through the use of ivermectin. So thank you very much for listening. I appreciate if there are any questions or contributions.
Thank you so much, Dr. Sambo, for that beautiful presentation. Very lucid, straight to the point, and details. Thank you so much. So we'll take comments and questions from the participants first. If you want to make a comment, you can raise your electronic hands. And let's keep the thanks coming on the chat. Okay, so Dr. Ifama says, thank you, Chief, for the presentation. Mazotti reaction is not a diagnostic method or procedure. There are other causes of the reaction. Do you want to react to that?
Okay, so I said it's the basis for the skin patch test. Okay, because it's sort of a controlled Mazotti reaction where a small amount of that DEC is applied to the skin, and then you witness the reaction. Okay, so it's more of a treatment side effect, but it can be used as a diagnostic modality, but it's not first line. That's not what you do now. You rather do a skin snip or a slit lamp examination.
All right, thank you so much. Okay, so a lot of applause to you on the chat. Dr. Justice Ibiti says thank you. Thanks so much for the wonderful presentation. Dr. Blessing Azuko Yamadi says thank you for the beautiful presentation. Dr. Laito is thanking you also for the lucid presentation. Dr. Lalekion says good morning. Thank you for the wonderful presentation. If onchocerciasis is the second leading infectious cause of blindness, which is the first? And then how can one differentiate onchocerciasis from lower infection? Well done.
Okay, so regarding the differentiation between the lower, I didn't really go into go deep into the differentials. So maybe I can check that and get back to you. Okay, but the first infectious cause of the blindness is trachoma, caused by the chlamydia trachomatis. So that's the leading infectious cause of blindness.
All right, thank you so much. Okay, so so trachoma is the leading cause. Is that what you said?
Yes.
Okay. So Dr. Itoha was asking what's the leading cause. Okay, you've already answered that, trachoma. Dr. Rita Wakama says thank you. Dr. Chris Adai says thanks for an excellent presentation, Dr. Sambo. And then Dr. Olaiton is adding Mazotti tests is contraindicated in patients with heavy infection because of risk of severe reactions. Thank you so much. First, she made a comment that Mazotti test is done. Okay, Dr. Thanks so much, Chief Sir. Microfilaria in peripheral blood as a diagnostic modality. Okay, let's react to that.
Sorry, what was the...
He's asking if you can do like a peripheral blood film to view the microfilaria as a diagnostic modality.
Yes,
Is it possible?
when you take the skin snip, you visualize it under the microscope to see the microfilaria.
Okay, so you don't use blood.
Well, the blood you can do ELISA and other, but for the diagnosis is the skin snip.
Okay, thank you. So Dr. Mamadou says that the diagnosis of onchocerciasis is based on a history of compatible epidemiologic exposure, clinical manifestations, and supportive laboratory evidence of infection. A skin snip biopsy is a gold standard for investigation of a patient, and then slit lamp examination can be used to look for wriggling microfilaria within the anterior chamber of the eye. Mazotti testing should be performed only in certain clinical circumstances. Then serology, antigen testing, and polymerase chain reaction are useful tools, though are not routinely available in endemic areas. Ultrasonography of subcutaneous nodules may be useful for identification of adult worms. Thanks so much, Dr. Mamodo, for beautiful add-ons. Dr. Blessing Azukoyamade says, thanks you so much for your presentation. Please, can you talk about the mass drug administration in endemic areas? What are the surveillance strategies? Okay, Chief, if you want to reiterate that point.
Okay, I think I mentioned them. So there are programs as the Onchocerca Control Program, which use the insecticide spray. Then we have that's the OCP. Then the APOC, that's the African Program for Onchocerca Control, that made use of ivermectin and also insecticide, environmentally safe insecticide. Then there's the expanded special project for the elimination of neglected tropical diseases that also use ivermectin. And then the Onchocerca elimination program of the Americas. So I think I talked a bit more about them in the slides. Maybe it's because of time that I just summarized these prevention strategies. Then regarding the lower, I think one of the ways to differentiate is that in lower, you can see the adult worm that crossing over the eye. Why in Onchocerca, it's just visualization of the microfilaria in the anterior chamber of the eye. So you may not see that worm that is crossing over, that is grossly visual in the eye. But I don't know. I'll just check if there are more differences between the Onchocerca and the lower. Thank you.
And then you add to the slide. Thank you so much. You can add it before you drop. All right, so Dr. Lighton says antigen test is also done more reliable than serology because it is only positive in active infection, unlike serology, which can be positive in the absence of active infection. Also, there's cross-reactivity in ELISA between different filarial parasites. Okay, so the molecular test can also be done with highly sensitive PCR assays, which have been developed but not routinely available. Thank you so much, Dr. Lighton, for that. And then Mahmoud is also adding subclinical or early infection, where microfilaria might not be readily available. Mazotti can be done. This is discouraged because of the severe reactions that might ensue. Okay, so rifampicin and azithromycin can also be used to kill the Wolbachia. Thanks so much, Dr. Lighton. Thank you, Dr. Mamodu, for the add-ons. All right, I can't see any electronic hands up. Yeah, I can't see any more comments on the chat. Thank you so much, Dr. Sambo. Well done. Okay, so at this point, I'll hand over to our teachers. Ma Christabel.
Oh, thank you so much, Dr. Sanda. I think Sambo, yes. Thank you so much for Sambo. That was wonderful. Dr. Mamudu, Dr. Lata, thank you. Dr. Awa, I was expecting to hear your voice. Dr. Linda, are you not in class? Dr. Awa. Dr. Ituma, Dr. Ifoma Ede. I'm still expecting to hear your voice.
I don't think Dr. Owen is in class today.
That's how I is not in class. Dr. Ituma, Dr. Linda is in class. It's strange. She usually contributes. Maybe she's busy. Anyway, the presenter did well. Yeah.
Good morning.
Morning.
Hello, good morning.
Dr. Ituma, good morning.
I'm sorry. Where I am is kind of noisy. I don't know if you can hear me.
I think it's manageable. The presenter did well though, so thank you so much. Thank you. I don't know if any of our teachers have anything to add. I noticed somebody mentioned, I don't know if she mentioned the use of dosage cycling. Dr. Sambo, you talk about.
She didn't. I didn't hear her. Dr. Sambo.
Yes, hello?
Okay, please can you react to that?
Sorry, what was the question?
Did you mention
Um,
dosage cycling?
Oh, yes,
Oh,
I
yes,
yes,
Oh,
100
back here.
milligrams.
Okay.
yes.
okay.
For 6 weeks, 100 milligrams daily for 6 weeks.
Okay. Okay. That's fine. And you know the reason why we give the dosage cycling?
Yes, ma. For the
Okay.
Wilbur, yeah.
Okay, that's fine. So thank you so much. Thank you. I don't know if any of our teachers have any. Dr. Dahatu, any comments? Any of our teachers, any comments? Okay, Dr. Sandal, once again, we say thank you. Thank you, thank you. You're quite a wonderful participant. Be quite encouraging. Thank you so much. This is also part to say thank you for all your sacrifices. No, most time, once we give a topic, you always do a wonderful job. You don't complain, you don't look for you, we don't pursue you. Always so active, ready to share, ready to give information. Thank you, thank you. And wish you success in the exam commencing next week. So congratulations, Dr. Sample. Thank you so much.
Thank you very much.
So, Dr. Ekele, thank you. Over to you.
All right, thank you, ma. Thank you so much, Dr. Sambo, and others who made comments on the contributions. Okay, so Dr. Zakia, please can someone help us share Dr. Bimpe, Dr. Mamodu? Thank you in advance. Hello, Dr. Bimpe. Dr. Mamodu. Thank you. Okay, thank you, Dr. Mamodu.
Okay, good morning, consultants, senior colleagues and colleagues. Thank you very much, Dr. Mamodu, for helping me to share the slides. I'll be taking us to typhoid fever under the following outline. So by way of introduction, typhoid fever is caused by Salmonella enterica serotype typhi. It's initially known as Salmonella typhi, but the new name now is Salmonella enterica serotype typhi, and to a lesser extent, Salmonella enterica serotypes paratyphi A, B, and C. So both typhoid fever and enteric fever are commonly used interchangeably. However, enteric fever is used to refer to infection by both the typhi and paratyphi serotype. Other Salmonella serotypes are non-typhoidal, and they all pose a significant public health challenge, particularly in regions where inadequate access to clean water and sanitation occurs. It is transmitted through contaminated food and water, making it more prevalent in the developing countries where hygiene practices are compromised. The genus Salmonella is composed of gram-negative, non-spore-forming rod-shaped bacteria and belongs to the Enterobacteriaceae family. These microorganisms range in diameter from around 0.7 to 1.5 micrometer and a length of 2 to 5 micrometer. They are facultative anaerobes, and they predominantly show perityphus motility. Next slide, please. So this is the structure of the Salmonella bacteria. You can see it has a capsule, villi, the plasmid, and the flagella, which aid in the motility of the organism. So typhoidal disease is not truly an intestinal disease and has more systemic than intestinal symptoms. Both the Salmonella typhi and paratyphi are the second and third most common pathogen causing extraintestinal disease behind following hepatitis A. Salmonella typhi is remarkably adapted to humans, who represent the only natural reservoir. The other Salmonella species are associated with animals. So for the paratyphi serotype, we have A, B, and C serovars. They are typically associated with clinically less severe disease compared to the Salmonella typhi serotype. So Salmonella typhi has a worldwide distribution in tropical areas, and it is associated with poor hygiene conditions. So areas of endemicity for paratyphoid fever are mainly Asia and Africa, with a particularly high incidence of 150 cases per 100,000 persons per year in China. Unlike Salmonella typhi, in which the only reservoir are humans, I've mentioned earlier that the paratyphi can be found in domestic animals. It remains a significant public health problem, particularly in low and middle income countries. WHO estimated that there are about 11 to 20 million cases of typhoid fever occurring annually, and resulting to about 128 to 161,000 deaths per annum. The highest incidence rates are found in South Asia, Sub-Saharan Africa, and Southeast Asia. The burden of typhoid fever varies greatly from region to region, with the highest incidence seen in India, Pakistan, South Asia, and Bangladesh. The paratyphoid fever global burden was estimated to be 4.8 million cases annually in 2010, and accounting for 33,000 deaths around that time. So in contrast to typhoid fever, paratyphoid species is rare in in contrast to developing countries where the typhoid fever is endemic, typhoid fever is rare in high-income countries where there is improved sanitation, clean water supplies, and effective public health measures. And then in the US, most cases of typhoid fever has been shown to be detected in international travelers. So with prompt and appropriate antibiotic therapy, typhoid fever is typically a short-term febrile illness and has a median days of hospitalization of about 6 days or less. If appropriately treated, it has a few sequelae and low risk of mortality, about 0.2%, while untreated typhoid fever is usually life-threatening, lasting for several weeks with long-term morbidity, often resulting from central nervous system complications. The case fatality rate in the US in the pre-antibiotic era was 9 to 13%. It predominantly, it affects children and young adults, particularly within the ages of 5 to 19, and children are more susceptible to the disease because of their underdeveloped immune system, and they are more exposed to contaminated environments. So the presentation in the young children could be atypical, and it could be range from mild febrile illness to severe illnesses leading to convulsion. In some instances, the infection may go unrecognized, the febrile illness may go unrecognized, and the patient first presenting with complications. So typhoid fever is often shows seasonal patterns with higher incidence rates during the rainy season in endemic regions. The increased rainfall can lead to flooding and contamination of water supplies, creating favorable conditions for the spread of the disease. The primary risk factor for typhoid fever include exposure to contaminated food and water, poor sanitation practices, lack of access to clean drinking water, inadequate sewage disposal system, low socioeconomic status, overcrowding, lack of education, limited access to healthcare services, gastric hypoacidity in patients that use PPI and antacids, the Salmonella cystosoma complex. It has been shown that Salmonella and cystosoma have a synergistic relationship. So most patients that are infected with cystosoma, if they have co-infection with Salmonella, it's usually difficult to treat and diagnose the infection due to this synergistic relationship. Other risk factors include immunosuppression, like HIV, sickle cell disease, and other causes of asplenia. Genetic polymorphisms in the PAC2 and PAC-GR regions have also been shown to be implicated as risk factors. Individuals traveling to endemic area, especially from a non-endemic region, are at increased risk of contracting the disease. The mode of transmission is usually via the fecal-oral routes, and the bacteria can survive in water or food, particularly under poor hygienic conditions. It contaminates water sources and food supplies, leading to new outbreaks. After 6 weeks, approximately 50% of the victims still shed the organism in the feces. This figure declined progressively with time, and after 3 months, only 5 to 10% are excretors. And by 1 year, the frequency is about 1 to 6%. We have chronic carriers of Salmonella typhi, whereby they excrete the bacteria continuously in their stool. They are usually asymptomatic, but continue to shed the bacteria for decades and sometimes indefinitely. The chronic carrier state is defined as an asymptomatic individual who persistently excretes Salmonella typhi organism for at least 12 months after treatment, or identification of a positive stool culture for Salmonella typhi about 12 months after the acute episode, or in some cases, positive stool cultures without a prior documented history of the disease. The chronic carriers are usually seen more commonly among the elderly age group, and it's more common in women with a female to male ratio of 3:1, and in people with biliary diseases. What happens is that the organism is harbored within the gallbladder, and occasionally it's carried in the large intestine without involvement of the biliary tract. all know the story of Typhoid Mary. She was the first Irish-born American. She was a cook, and the first person to be identified in the US as being an asymptomatic carrier. She infected more than 100 people with typhoid fever before she was finally quarantined. So pathophysiology. The pathologic events of typhoid fever are initiated in the intestinal tract after oral ingestion of between 1,000 to 1 million typhoid bacilli. The organism penetrates the small intestinal mucosa and rapidly makes its way to the lymphatics, the mesenteric nodes, and the bloodstream. Within the guts, the bacteria are engulfed by phagocytic cells, which then present them to the macrophages of the lamina propria. So the organism uses its toll-like receptor 5 and 4, coupled with the CD14 complex. And then the macrophages recognize pathogen-associated molecular patterns such as flagella and lipopolysaccharides. So macrophages and intestinal epithelial cells then mobilize the T cells and neutrophils with interleukin-8. This results in inflammation, hopefully suppress the infection in most cases. So the organism has specialized fimbriae which adhere to the epithelium over clusters of lymphoid tissue in the terminal ileum. The bacteria then induces their host macrophages to attract more macrophages. The capsular antigen, VI antigen, is one of the most important virulence factor for the Salmonella typhi organism. So the Salmonella typhi that has the VI antigen uses this antigen to mask the pathogen-associated molecular patterns, thereby avoiding the neutrophil-based inflammation. And this is absent in most of the paratyphoid species, and that's why the inflammation is in such infection by paratyphoid species is adequate to suppress the infection. And therefore, infection by paratyphoid species is less severe than that caused by the typhoid species. Two regions, the VIA and the VIB, contain the genes for the VI antigen and are located on the Salmonella pathogenicity island, commonly the pathogenicity island 7. It can also be seen on 15 as well as 18. So the neutrophils in the small intestine are not activated, thereby facilitating systemic dissemination, and the organism may sequester itself as a biofilm on the gallstone or within the gallbladder epithelium, which is responsible for the chronic carrier state. So this is just showing the pathophysiology explained earlier. Because of time. Okay, next slide, please. So the mode of transmission I've already mentioned is fecal-oral route, and then the 4 Fs are implicated in spreading the organism. That's flies, fingers, feces, and fomites. They afflict people living in or traveling to endemic areas, and those people that lack clean water, adequate sanitation, and hygiene, so commonly known as the WASH. Next slide, please. So clinical presentation, incubation period ranges from 7 to 14 days. During the first week, the patient presents with fever, headache, and abdominal pain. They have a Faggot sign is prominent in such patients. That's pulse temperature dissociation. Abdominal pain is usually localized to the right upper quadrant, but in some cases it could be diffuse. Commonly, they can also present with dry cough, myalgia, sore throats, alteration in bowel habits, constipation alternating with diarrhea. By the end of the first week, enlargement of the spleen is usually noticeable, and then such patients have an evanescent classic rash known as the rust spots, usually seen on the trunk. So the next slide is just showing us the rust spots. It's difficult to appreciate in dark-skinned individuals. It's salmon-colored blanching truncal maculopapular rashes, and they resolve within 2 to 5 days. They are caused by bacterial emboli to the dermis. Occasionally, they may be seen in cases of shigellosis or other non-typhoidal salmonellosis. So by the 2nd week, the fever becomes more continuous. The classic stepladder pattern that was once the hallmark of typhoid fever now is seen in only about 12% of cases. And in most contemporary presentations, fever has a steady but insidious onset. So most children present with abdominal distension and soft splenomegaly is seen. The relative bradycardia or Faggot sign, I've explained that earlier. So by the 3rd week, the individual still remain febrile, becomes more toxic and anorexic with significant weight loss in some cases. The conjunctiva may be infected and the patient becomes tachypneic. Abdominal distension may become severe, especially in children. The patient's illness evolves into the typhoidal state, which is characterized by apathy, confusion, and even psychosis. In this period, there is often intestinal involvement manifesting clinically by diarrhea and their complications of intestinal perforation and hemorrhage. This complication may be masked by the use of steroid. At this point, overwhelming toxemia, complications like myocarditis and intestinal hemorrhage may occur, leading to death. So by the 4th week, there is slackening of the fever and the patient clinically improves. Weight loss and debilitating weakness may last for months. Other complications like pneumonia, arthralgia, and urinary symptoms jaundice occur. So these are the complications. I've already mentioned most of them in the clinical features. Relapse is important to know that relapse is defined as the recurrence of symptoms. It's also a complication in which the patients have laboratory confirmation of the Salmonella typhi from a normally sterile site within 1 month of completion of treatment for the typhoid fever. Relapse commonly occur in less than 10% of patients, and it usually takes 1 to 3 weeks after, it occurs 1 to 3 weeks after clinical recovery. And in such cases, extension of the antibiotics is recommended. So for diagnosis, culture is recommended. Blood and bone marrow culture show a sensitivity, specificity of about 100%. So bone marrow culture is usually the gold standard. Stool culture may be used by the 2nd to 3rd week. And then by the end of the 3rd week, urine culture can also be used. Other immunologic tests have been used in the colonal area. Next slide, please. So the wider serologic test has been used initially. However, because of its low specificity, it has a high false positive result because of cross reaction with other Salmonella strain. So it's no longer advocated. Next slide. Molecular tests, the nucleic acid detection method, for example, the polymerase chain reaction assay or whole genome sequencing can be used to detect the genetic signature of the organism, including resistant strain. However, meta-analysis have shown that the rapid diagnostic tests have moderate diagnostic accuracy and can be combined with blood culture to improve its sensitivity. So other tests that can be done to rule out other differential diagnoses include thick and thin blood smear for malaria, parasite, lumbar puncture. Full blood count usually show neutropenia and leukopenia. ESR and C-reactive protein is usually elevated. PT is usually elevated. Fibrinogen levels, liver function tests may also be deranged. Then ECG test, X-ray, and scan can be done to rule out complications that may arise from the infection. So treatments, management of typhoid fever involves both antimicrobial therapy in an attempt to eliminate the infection, and also supportive care to manage symptoms and prevent complications. So the first line choice of antibiotics is usually the fluoroquinolones, ciprofloxacin. You can also use the 3rd generation cephalosporin. So in cases of resistance to ciprofloxacin, azithromycin and carbapenem, usually meropenem, can be used. And then duration of treatment is 7 to 14 days, or can be prolonged to 10 days to 14 days. 10 days in cases of severe diseases. So management of complication, hospitalization, particularly for those with complications such as intestinal perforation or sepsis, then addition of anaerobes like addition of metronidazole in cases to cover for gram-negative organisms is also advocated in such patients with complications like intestinal perforation. Surgical intervention is recommended in patients with perforation. Small bowel resection can be done in patients with multiple perforation. Cholecystectomy can also be done, especially in patients with chronic carrier states. So next slide. Supportive care includes hydration, usually IV fluid. In severe cases, or ORS can be given in patients with mild to moderate disease. Then ventilation and oxygenation may be required in patients with pulmonary complications. Steroids are recommended for severe cases, especially if there is central nervous system involvement. So the steroid of choice is usually IV dexamethasone given 3 mg per kg over 30 minutes and followed by 1 mg per kg 6 hourly. Nutritional support is paramount in such patients, and then they can come with anemia as a common complication. So management of anemia as appropriate. So prevention and control, we have 3 available typhoid vaccines, 2 of which are unconjugated, the inactivated VI capsular polysaccharide antigen vaccine, and then the enteric-coated capsule, that's the typhoid 21A, which is a life attenuated oral vaccine, capsule that can be given. So for the inactivated vaccine, it's usually administered at the start dose IM 0.5 mils, given about 1 to 2 weeks before travel to endemic areas, and then it can be followed by 2 to 3 yearly booster doses. For the enteric-coated capsule, a total of 4 doses are taken on alternate days, and then booster doses are required after 5 to 7 years. So the newer vaccine is the conjugated VI capsular polysaccharide vaccine conjugated with the tetanus toxoid. It is recommended by WHO because it is more immunogenic, and it's preferred because it can be used across all age range. For the capsular vaccine, it's contraindicated in patients below the ages of 2, while the enteric-coated capsule is contraindicated below the ages of 6. So this conjugated vaccine is more recommended by WHO. Prevention and control. Preventing typhoid fever involves the combination of vaccination, improved sanitation, access to clean water, and public health education. Infrastructural developments, community engagements, and public health education are all important. During outbreaks, prompt identification of cases, treatment of affected individuals, and distribution of clean water and sanitation supply are key to controlling the spread of the disease. So this is the National and Environmental Scorecard by the World Health Organization. So the WASH, that's adequate drinking water, adequate sanitation, and hand hygiene. So it has been postulated that 71% of population without safe drinking water and 68% of the population without safe sanitation. This will lead to the health impact, which is 76% of death from diarrheal disease caused by this unsafe drinking water and sanitation. Okay, we'll go through this in the slide. Prognosis. The prognosis is usually favorable if early treatment is initiated, and the case fatality rate is less than 1% with early identification and treatment. However, delay in treatment may lead to life-threatening complications and may even result in death. Public health measures such as vaccination, improved sanitation are important in reducing the global burden of the disease. In conclusion, typhoid fever remains a significant public health challenge, particularly in regions where inadequate access to clean water, sanitation, and healthcare is seen. While advances in vaccination, antibiotic therapy are advocated, it doesn't underscore or even preclude the use of proper sanitation and hygiene. Raising awareness, investing in prevention, and supporting global health initiatives can reduce the burden of typhoid fever and move closer to a world free from this preventable disease. Thank you very much. I would like to appreciate Dr. Blessing Amadi because I used her slide with some modifications from Netscape and Satnos. Thank you.
Thank you so much, Dr. Zakia, for that detailed presentation. So now we'll take comments and questions from the participants first, and then our teachers will come in. And let's keep the thanks coming on the chat. Dr. Laito Abimbola is saying thank you for the lucid presentation. Okay, if you would like to make a comment. Okay, Dr. Yusuf, please go ahead.
Thank you, Dr. Zakia. Hello, am I audible, please? Hello?
Yes, you are.
Yes, I can hear you.
Okay, good. Thank you, Dr. Zakia, for the beautiful presentation, very extensive. Just a little add-on, first, especially regarding the pathogenesis, just for us to have a clear picture of what exactly is happening in typhoid. Usually, of course, we know it's usually an infectious agent that is being transmitted orally. And after ingestion of the organism, it penetrates the small intestine. And then from there, it gets access to the lymphatics, the mesenteric lymph nodes. And then it's actually being taken up by the reticular cells, the macrocyte, the macrophages, and so on. So the bacteria is actually being engulfed. Now, the first stage where it gets access into the bloodstream is actually known as the stage of the primary bacteremia, because there are two phases in the pathogenesis. You have the primary bacteremia as well as the secondary bacteremia. So the first time you get access into the bloodstream is the primary bacteremia, and at this stage, it's been engulfed by the macrophages, the mesenteric lymph nodes, and so on. Now, during this phase, there is no any clinical manifestation because the polysaccharides of the bacteria actually a lot of antigens on the bacteria prevents the innate immune response recognition, also the toll-like receptors too on the bacteria. So this prevents the immune response at this stage. That's the stage of the primary bacteremia. Then also there's also prevention of neutrophil activation and so on. Then the next phase is the phase of the secondary bacteremia, and during this phase, that is when the bacteria now rapidly replicates within the macrophages, the neutrophils, and they are now being released gradually, causing what is known as a recurrent waves of bacteremia. So this bacteria is now being released for the second time. They now get access to the bloodstream for the second time. Now, it is now during this phase of secondary bacteremia that the clinical manifestation now sets in. And at this time, the bacteria now moves into various organs, including various organs of the body, including the Peyer's patches in the terminal ileum. And then later, there may be typhoid perforation. So the clinical features that we now see is during the phase of secondary bacteremia. And the fever that we see in typhoid fever is usually very prolonged. And what is responsible for that prolongation is as long as the macrophages are still releasing this bacteria into the bloodstream, patient continues to have the symptoms, even despite being on treatment. And that's why even if you are treating them, if you are giving them even very potent antibiotics, you still have to continue. The fever doesn't come down quickly. It takes time. Usually it takes up to 7 days before you now start seeing the fever start coming down. Until and unless when all the bacteria has been released from the macrophages that have initially engulfed them before the fever subsides. That's for the pathogenesis. So we should know that there's phase of primary bacteremia as well as phase of secondary bacteremia. Then for the evaluation too, it's important that we know generally from food log count that there's no leukocytosis, generally leukopenia, because all the white blood cells are being engulfed. The white blood cell engulf the bacteria, and for them to be released, there will be lysis of these white cells. So there's usually no leukocytosis. Once there's leukocytosis, we must suspect complications, especially intestinal perforation. So we should try to also know that. Then for the serological test mentioned too, to know that it's actually not being advocated again, and it's because of various reasons, a lot of false positive. But there could be a lot of cross-reactivity even with malaria. Studies have shown that even someone that is having malaria can also have positive or high titer value for wider test. Then there's false negative as well too, because it's an antibody test. So usually, it's even possible that before this antibody will be formed, if wider test is done, one will not be able to fit it. So there's false negative. There's cross-reactivity with other things, and also there's inability to differentiate between current infection from vaccination. So it means that someone that is even vaccinated for typhoid fever can also have positive wider test. So based on all these reasons, that's why wider test has been phased out, as it's not a test that we use in making a diagnosis again. Then we can also do histology in addition to the investigation that she mentioned. And the hallmark histologic feature that we see in typhoid is actually there will be aggregates of macrophages, and there will be infiltration of tissues. So we can also do histology too as part of the investigation of choice too. So thank you. These are my few comments.
Thank you so much, Dr. Yusuf, for that beautiful add-on. Please, what specimen do you use for the histology?
Usually the lymph nodes, because there are sometimes you can see lymph nodes can be taken, or maybe postmortem sometimes, but usually lymph nodes.
All right, thank you so much. Okay, so Dr. Florence Kalamawa is saying thank you so much, Dr. Zakia. You're well appreciated. Our Chief Dr. Poki is applauding you, Dr. Zakia and Dr. Sambo, for your presentation. Says thank you for always representing. Dr. Mohodu says thanks so much. Is saying paratyphy more common in urban and typhy more in rural? Does it still stand for those in developing countries? Dr. Zakia.
Well, population-based studies, there are several studies that have shown that typhoid fever is more common in rural areas compared to urban areas, but they are just studies that were quoted. So I didn't see it in any standard text.
All right, thank you so much. Dr. Laison says, what are the differential diagnoses?
Okay, sorry, I missed the differential diagnosis. So malaria can be a differential. All other fevers that will cause this Farget sign, like yellow fever, brucellosis, chloralemia, drug-induced fever, like secondary to beta blockers, can also be differential of typhoid fever. And then the raw spot that we see can be seen in patients with, I think, leishmaniasis and rickettsial diseases. Similar rashes can be seen. So rickettsia, leishmaniasis, then in the chronic stage, it can be confused with TB because of the prolonged fever, complications of cough setting in. Even other causes of acute abdomen, appendicitis, can be differentials. I don't know if there are other differentials I didn't mention.
All right, thank you so much. Okay, she's asking viral hemorrhagic fevers can also be a differential. Okay, she has mentioned yellow fever. Thank you so much. Okay, I can't see any other electronic hands up. So at this point, I'll hand over to our teachers. Christabel.
Oh, thank you so much, Dr. Zakia. Thank you, Dr. Ekele. I don't know if Chiku is still in the house. Do you have any comments? That was quite wonderful. Dr. Dahatu, any comments?
Okay. You see, everybody's fine with your presentation. So thank you so much, Dr. Zach. We appreciate your time. Thank you so much.
Thank you, ma.